Next is classification of depression, classification on the basis of severity. So, in case of severe depressive episode, appearance, dress, and grooming may be neglected. Facial features characterized by a turning downward of the corners of the mouth, reduced rate of blinking, shoulders stooped low, and head inclined forward, downward gaze, reduced gestures and movement. Some patients may maintain a smiling exterior despite deep feelings of depression. Mood. The patient's mood is one of misery, characterized by pervasive low mood. The patient will say, every day I feel very low. Pervasive. I don't remember when I was happy the last time. From day till night, from the time I open my eyes, I feel bad, I feel worse. And which is different from ordinary sadness. Now, the mood is often worse in the morning. This is known as diurnal variation. This is very common in severe depression. Whenever you ask the patient, see, sleep difference is also a criteria by which you can identify. So, if you say that, how is your sleep? Then the person says it's disturbed. Then you ask, when is it disturbed? Do you feel worse after you wake up, or do you start feeling worse in the evening? So when the person reports he starts feeling worse in the evening, that's a sign of mild depression or moderate depression. But if the person says that, first of all, the person would be waking up before his normal time. So if the person wakes up at 8, the person will be waking up at 4 a.m. or 5 a.m. And the person will feel horrible. The person will start feeling worse right from the time he's waking up. That is called the diurnal variation, very characteristic of severe depression. Next is depressive cognitions. So, negative thoughts, which may be divided into feelings of worthlessness, in which the patients may feel that they are failing in what they do and that others see them as a failure. Pessimistic thoughts, which lead to ideas of hopelessness, leading to ideas or plans of suicide, and feelings of guilt, which take the form of unreasonable self blame about minor matters. Next, goal directed behavior will be lacking, lack of interest and enjoyment. Psychomotor changes. So, psychomotor retardation is frequent. Retardation means where the person does not feel like doing anything. The retarded patient walks and acts slowly. Slowing of thought is reflected in their speech as well. Agitation is a state of restlessness that is experienced by the patient as inability to relax and is seen by an observer as restless activity. Sleep disturbances, diurnal variation in mood, loss of appetite, loss of weight, constipation, loss of libido, and amenorrhea, which is among women. That is, woman has difficulty in periods, basically. These are commonly present in severe depression. Okay, just a minute. Okay, so are commonly present in severe depression, and other features include psychotic features, depersonalization, obsessional symptoms, panic attacks, and more rarely, dissociative symptoms, such as fugue or loss of function of limbs and pseudodementia among elderly patients have also been found to dominate the clinical picture. So then it gets very difficult for us to differentiate what it is actually. And remember, last time also I was clearing this to the students that we follow a hierarchy known as Fowler's hierarchy. So whenever a person satisfies the criteria for depression, we treat the person for depression, even if there are symptoms of anxiety, because in Fowler's hierarchy, schizophrenia comes first. Next, actually, first comes any kind of organic disorder. All types of organic disorder. It could be mental retardation, it could be dementia, it could be other forms of organic disorders due to temporal lobe epilepsy and many others. So that comes first. Next comes addiction, substance abuse, because substance abuse can cause every type of psychiatric illness that we are talking about here. Next comes schizophrenia. So, if a person satisfies any criteria for schizophrenia, treatment for schizophrenia starts first. Next comes depression. So, and after that comes anxiety disorders. So, we treat somebody for anxiety disorders only if we are clear that the person does not fulfill any criteria of depression. Only then we start treating a person for anxiety disorders, because in depression you will find many features of anxiety disorders, like dissociative symptoms, very common among women in India. You go to a government hospital, you will often find women coming with dissociative symptoms, and after you take their case history, after a few days, you will realize that this person is suffering from severe depression. There are many psychotic episodes which these women have, and after again later on, you will see that the person is suffering from depression. Because see, the cultural acceptance for physical disorders is more in our society than for mental disorders. You are not, so this is the wedding season, right? So nobody is feeling, so there might be a person who does not want to go to a wedding. You might not feel like going to a particular wedding, but if you tell your friends or your family that I don't want to go because you feel nobody is going to listen to you. They might even feel ki, if you go to the marriage party, you will meet other people, and that is going to make you feel better. So they won't believe you. Rather, if you tell them that PCOD and something else, that is kind of more acceptable. And these are right now the more acceptable terms, which are completely psychological. Trust me, PCOD, asthma, migraine, these all have a huge psychological component. These physical disorders, these physical conditions. Remember, these are all conditions. They do not have any particular treatment. Migraine does not have any particular treatment. Asthma doesn't have any particular treatment as such. They have pumps which enable you to breathe. But again, it has been seen that it is a psychogenic disorder. That is, it is mainly happening during times of stress. PCOD, again, a condition, something which main reason is stress.